diabetes associated emergencies are frequent, which include hyperglycemic states like DKA, HHS, and also the hypoglycemic coma. To focus on this situation, HTS have designed its next topic, emergencies in type 2 diabetes and how to manage. As a speaker, we have Dr. Ambar Basu from UK. He will join us virtually. He is the Training Program Director, Professor in Medicine of Royal College of England and Consultant Endocrinologist. As a speaker, we have Dr. Sanjay Shil, Consultant Physician attached to Peerless Hospital, Kolkata, and Dr. Mridul Bera, one of the eminent medical consultant and founder member of HDS. I'd like to request both the chairperson to please come over the stage and introduce our speaker.
Are you? Yeah. Dr. Ambar, he's just testing your voice.
Okay. 1, 2, 1, 2. Good afternoon.
Disturbance here.
Good afternoon, Midul. Good afternoon, Sanjay. Good to see you.
Good afternoon.
Shubha Mahala.
Shubha Mahala. You also. So today we are here to speak. Just a moment. Good afternoon, Ambar.
Good afternoon. Good afternoon, Sanjay.
Shubha Mahalaya.
Shubha Mahala.
We are meeting after a 1 year gap.
1 year.
So it's a sunny morning here. So Dr. Ambar Basu from UK will be delivering the speech on emergency management in patients of diabetes mellitus. So here, yes. Okay, Ambar.
Thank you. I can start sharing my screen.
Yeah.
You can share your screen number.
Okay, let me just get it. Okay. Is it visible?
It is. Yes, it is.
Okay, that's great. Good afternoon, everyone. Shubha Mahala to the audience. And it's again a privilege to be coming back and speaking to you, albeit online. 1 year has gone by. Thanks, Sanjay. Thanks, Mridul, for the opportunity. So over the next 20 minutes or so, what I will talk to you about is emergencies in type 2 diabetes and how to manage. And the topics which I would like to cover, because it's a short time, one would be the hyperosmolar hyperglycemic state. And the second one, which is becoming a bit of a challenge these days, is euglycemic diabetic ketoacidosis. So let's start with the hyperglycemic hyperosmolar state. Now, we all know that hyperglycemic hyperosmolar state, or HHS, and the diabetic ketoacidosis are the two most serious complications form of diabetes. And both of them do carry a risk of mortality. But when we compare the two, the HHS has got 10 times higher mortality than diabetic ketoacidosis. Fortunately, it's rarer, but the mortality rate is significantly higher. However, because of better management and better identification and understanding of the disease process, the incidences are declining, fortunately. So what are the precipitating factors for development of hyperosmolar state? Generally, these are infections or any acute major illnesses such as myocardial infarction, cerebrovascular accident, renal failure, pancreatitis, sepsis. There are certain drugs which affect the carbohydrate metabolism, such as glucocorticoids, high-dose thiazide diuretics, atypical antipsychotic drugs. Sometimes compromised water intake can affect it as well, particularly in older people, and can lead to severe dehydration and HHS. And very rarely, though, undiagnosed diabetes may present as HHS, although this is much rarer as compared to diabetic ketoacidosis as a
Dr.
presenting.
Basu?
Yes.
Dr. Basu? Dr. Bera, you just reduce these thumbnail videos.
Let me see. Shall I come out of sharing screen?
Yes, thumbnail video is there.
On my screen, it is reduced.
No, there is no video on this. I can only see the content.
Okay, you can continue.
Okay. On this slide, what I'm looking at is mortality and hyperosmolarity, because there is slight difference in definition of hyperosmolarity in different countries. Like in the UK operates slightly different to so this is figures from the United States. But what we see here, that higher the osmolarity, and if it is beyond 300, there is a significant rise in mortality. So the hyperglycemic hyperosmolar state does bring in mortality with it. And in this slide, what we see that any osmolarity above 300 actually increases the mortality. So these are the American data. So let's talk a little bit about the pathogenesis of this, and two main hormone dysfunction we will talk about here. One is, of course, the insulin deficiency along with resistance, and then glucagon excess. And there are also counter-regulatory hormones such as cortisol, growth hormone, catecholamines, which also come into play. One thing I'll try to address is why are ketones typically present in ketoacidosis, diabetic ketoacidosis, and not in HHS? So in this cartoon, on our left-hand side of the screen, what we see is the hyperosmolar state where there is a relative deficiency of insulin. And on the right-hand side, we have the absolute deficiency of insulin. So these are the type 1 diabetes patients, and these are type 2 diabetes patients. Now, hyperglycemia is common in both, but in type 1, there is also the ketone body production, which leads to the acidemia and ketoacidosis. And this pathway is a bit more clearer in that respect. So if we start with the type 2 diabetes, where there's a relative insulin deficiency, that will lead to glycogenolysis, the counter-regulatory hormones, that leads to gluconeogenesis and diminished glucose utilization, all leading to hyperglycemia, glycosuria, loss of water, dehydration, hyperosmolarity. But there is absent or minimal ketogenesis on if it is a type 2 patients who've got relative insulin deficiency. But there's a bit of background sound I can hear. Is somebody talking? I can hear a bit of a background talking going on. Anyway, if we come to look at the absolute insulin deficiency, which is typically in type 1 patients, then we have the situation when there is increased lipolysis, increased I can still hear somebody talking in the back, another screen probably. Anyway, so that leads to ketoacidosis, and that's the situation we find in diabetic ketoacidosis. So to differentiate, it is about absolute insulin deficiency versus relative insulin deficiency. So there is still enough insulin available in type 2 patients to avoid them to going into ketogenic process. So that's the reason. The other factor which is important in hyperosmolar state is how to calculate the osmolality or osmolarity. The formulas which are generally used is 2 times sodium plus glucose plus urea. Now, if you use milligrams per dl for glucose and blood urea nitrogen, so this is the formula to use. So let's just look at a case scenario. This is a hypothetical case. So she's a 71-year-old lady with type 2 diabetes for a length of time, 10 years, raised BMI, takes Lantus, 40 units, metformin, one morning drowsy, lying on the floor. Initial assessment showing a degree of hypotension, tachycardia, oxygen saturation was reasonable. Initial set of bloods showed a normal sodium, normal potassium. Glucose was very high at 45 millimoles per liter. Bicarb was normal at 24, pH 7.35, urea raised at 11.8, and blood ketones negative. So this could be a sort of a relatively standard presentation where you could suspect whether the patient has got hyperosmolar state. So we would like to calculate this lady's osmolality. So if you use the formula like this, and it will come around 326.8. So what is the definition of hyperosmolar state? Now, this is the definition which is used in the UK at the moment. Americans Diabetic Association, they use osmolality of 300 and above. UK is slightly higher at 320 and above. And the characteristic features are marked hypovolemia. So this is the key. The degree of dehydration is severe in HHS. The measured or calculated osmolality is equal to or more than 320. Marked hypoglycemia over 30 millimoles per liter. In Indian terms, it will be more than 600 milligrams per deciliter. But the key feature is that without significant hyperketonemia. So in the UK, we can do finger prick blood ketones. So if it is less than 3, then that would be regarded as no significant hyperketonemia. And if you do a venous blood gas, if the pH is more than 7.3 and the serum bicarbonate is more than 15, then that would be compatible with the diagnosis of HHS. Now, if you're looking at the ADA guidelines, they use serum bicarb of 18. So there is a bit of a variation between different countries how they define HHS. So if you would like to have a look at this guideline in future, this is a very well presented document, and the management I'll be talking to you about is from this one. This is from the Joint British Diabetes Society Inpatient Guidelines of Management of Hyperosmolar Hyperglycemic State. And if we start with the initial assessment of these patients, and as I mentioned, hypovolemia or the fluid deficit is the biggest issue in HHS. And from this figure, what we can see, for an average 60 kilo individual, the fluid deficit could be as high as 13 liters. For a 100 kilo individual, up to 22 liters. There is also a deficit of sodium, chloride, and potassium. Now, acute cognitive impairment is not necessarily always present, and it may be due to dehydration, not specific to HHS. Now, those who have been studying diabetes for a long time, this used to be called HONC or hyperosmolar non-ketotic, and sometimes non-ketotic coma. So, we always used to think that, the cognitive impairment is a big element of HHS, but if they present a bit early, that may not always be present. However, the cognitive status issues are much more prominent when the osmolality crosses 330. So clearly, higher the osmolality, more complex the problems are. The hypovolemia itself will manifest as hypotension, tachycardia, signs of dehydration such as sunken eyes, dry tongue. But one thing we have to remember that despite severe electrolyte losses and the total body volume depletion, the person may not always look that dehydrated. And I'll discuss the reason why that might be the case. Having said that, the HHS can have marked effect on cerebral function, and the possible causes are cerebral edema, in severe cases, electrolyte imbalance, acute changes in osmolality, dehydration, underlying sepsis, hypoglycemia during the treatment, and acute kidney injury. So how would we assess the severity of the situation? Because based on that, we have to decide where these patients are looked after. So whether they will be on an acute medical unit or they have to be stepped up to level 2 or high dependency unit. So these are some pointers. If one's measured or calculated osmolality is greater than 350, sodium more than 160, if the venous or arterial pH is less than 7.1, so this could be a mixture of HHS and DKA, severe hypokalemia, severe hyperkalemia, low GCS, hypoxia, severe hypotension as defined by systolic blood pressure of less than 90, tachycardia, severe bradycardia, low urine output, significantly high serum creatinine, hypothermia, macrovascular events such as myocardial infarction and stroke. Clearly, many of these will coexist with another underlying serious acute medical condition and any other serious comorbidity. So for these patients, we have to decide and whether we look after them, and in most cases, it will be level 2 or high dependency unit. The goals of treatment are mainly to normalize the osmolality, replace the fluid and electrolyte losses, and normalize blood glucose. And as you can see, normalizing blood glucose is number 3 as a priority, as opposed to fluid and electrolyte loss and correction of osmolality. The other goals are, prevention of arterial and venous thrombosis, because it's a severely dehydrated state, and these patients are usually elderly with other comorbid conditions. So they're at a significant risk of having venous thromboembolism or arterial thromboembolism. Other potential complications such as cerebral edema, central pontine myelinosis, which may happen if rapid correction of sodium is done, and osmotic demyelination syndrome. Foot ulceration, this has been recognized as a significant inpatient complication of patients with HHS because of poor mobility, patient lying in bed, and poor heel care that leads to foot ulceration. So it's important that this particular aspect of care is looked into. So let's get to the management. So first of all, when we do our clinical assessment, does the history suggest any underlying significant acute medical situation, such as sepsis or a vascular event? And they have to be managed as well as managing HHS, or has there been a recent change in medication? Then comes assessing the degree of dehydration, finding the source of sepsis, vascular event, mini-mental state for cognitive assessment, and assessing for any contraindication of low molecular heparin. Now, in the olden days, patients with HHS used to be treated with full anticoagulation, but that's not the recommendation currently. Only if there is evidence of existence of a DVT or acute coronary, at that stage we will use full anticoagulation. The next, we will assess the foot risk and daily foot checks. So this is step-by-step management of HHS, and this has been done in a very timely fashion. This is the first hour management, and the first hour is it's very similar to how you manage your patients with diabetic ketoacidosis. You run a liter of normal saline over an hour. And if the patient is significantly hypotensive with a systolic blood pressure of less than 90, you can give some extra fluid as well. But one word of caution, if the patients are elderly with comorbidities, particularly heart failure, then that has to be sort of taken into consideration. As regards to the insulin, a general principle not to start the insulin straight away. However, if there is a situation where the blood ketones are greater than 1, but the patient is not acidotic, so venous pH is more than 7.3 and the bicarb more than 15, then start 0.05 units per kilogram per hour of insulin right at the start. If there is significant ketonemia, if the blood ketones are greater than 3, or there is ketonuria, where the urine ketones more than 2, with a low pH, less than 7.3, and a low bicarbonate less than 15, so this is a mixed DKA-HHS picture, so they need to be managed as diabetic ketoacidosis from the insulin point of view, not 0.1 units per kilogram per hour. So that's the thing about insulin you have to remember in HHS. The other management would be doing some investigation. So it is quite a bit of intense monitoring which is required. So measurement of serum osmolality on an hourly basis, monitoring of blood glucose, gases, and then doing a panel of full blood count, blood cultures, ECG, chest X-ray, looking for underlying cause of what may have led to the HHS, which may be needed. Monitoring-wise, as I said, monitoring of the osmolality on an hourly basis, and this to be plotted in a chart. The next 6 hours, from hour 2 to hour 6, again, that needs to be continued. And at this stage, what we are looking at to see some biochemical improvement. So what we are aiming for is a gradual decline of osmolality, so between 3 and 8 milliosmoles per kilogram per hour decline, to carry on giving further fluids, again keeping in mind for elderly patients or patients with comorbidities such as heart failure. The target is to achieve a positive fluid balance of 2 to 3 liters by 6 hours. Now, I did mention to you that I'll come back to this one, why sort of using fluid first is important in HHS before we think about whether we give insulin, which we don't do in patients with diabetic ketoacidosis. So if you look at this cartoon here, so in equilibrium, when glucose and everything is fine, the intracellular fluid and extracellular fluid, there's no fluid shift between them. When there is hyperglycemia in section B, that will start to draw water out of intracellular fluid into the extracellular fluid, and that will keep the volume within the extracellular fluid compartment. But of course, at that stage, we will start to see osmotic diuresis because of hyperglycemia. When that gets accentuated, then more fluid is drawn from ICF into ECF, but because of the increased osmotic diuresis, the ECF again starts to contract. So at this stage, we are starting to see signs of dehydration, hypovolemia. Now, if insulin is given when the volume is already contracted, what insulin does, insulin will drive the glucose back into the cells, and along with the glucose, water will follow. So that means this ECF will get even more contracted. So if we give insulin before correcting the fluid deficit, we will sort of accentuate the dehydration. So that's why in HHS, the fluid is the first sort of treatment to make sure the patient is properly hydrated before we consider giving insulin for hyperglycemia. However, the point to be made here that if the patient has got ketones more than 1, or it is a DKA HHS mixed picture, then insulin needs to be started from the beginning. So again, laboring the point about insulin here, one of the aim of giving insulin is to make sure to avoid hypoglycemia. to keep the blood glucose between 10 and 15 in the first 24 hours. So we are not aiming for a normal blood glucose there. And if the blood glucose falls below 14, then to start 10% glucose along with normal saline. The electrolyte which is most important in this context is the potassium. So there is some guidance about how much potassium to give based on the levels. So if the potassium is over 5.5, nothing is required. If it is between that, this is just a replacement potassium with the fluid. If it is below that one, then it is some senior input to decide how much potassium to replace and where they need to be cared for, usually level 2. From 6 to 12 hours, similar sort of plan is to continue with the management and monitor the patient to see if all the metabolic parameters are getting better. And at this stage, of course, they need to be referred to the specialist team in this. That's how it works over in the UK. And then between 12 to 24 hours and then before discharge, just need to follow it through as regards to how the patient is getting on. So just a quick top tips about the fluid management. Isotonic solution is preferred, so normal saline. And the rationale is the fluid is hypotonic in patients with HHS when they compare with the serum osmolality of the patient. So normal saline will do fine. Fluid replacement alone will lower the glucose, which will lower the osmolality by a shift of water intracellularly, as we discussed. This will cause a rise in serum sodium and a fall of glucose. Will result in 2.4 millimeter rise in sodium. So this is not an indication to give hypotonic saline. So this is expected. That's not an indication. However, though, if the osmolality is not declining despite adequate normal saline replacement and an adequate fall of glucose is not being achieved, then you may wish to consider dextrose, so like 0.45 sodium chloride can be used. A fall of sodium should not exceed a rate of fall of sodium should not exceed 10 millimoles in 24 hours. As we know, that can lead to central pontine myelolysis. Management of insulin, we again have talked about it. So not to start insulin at the beginning. However, if the patient has got a degree of ketonemia, then insulin needs to be started. And the fall of glucose of 5 millimoles per hour is ideal. Goes without saying, the other management would have to be treating the underlying cause, antibiotics for sepsis. If patient has got acute coronary syndrome or myocardial infarction, that needs to be treated as well. And as I briefly touched on this before, regarding anticoagulation, if there is evidence of or a suspected thromboembolism, that's when we will give full anticoagulation, but otherwise we will use prophylactic anticoagulation with low molecular weight heparin, and again, laboring the point of foot protection. How would we define resolution of HHS? Now, there's a various definition which has been offered and is not agreed everywhere. However, when the calculated osmolality falls below 300, hypovolemia has been corrected, cognitive state back to premorbid state, and glucose has fallen below 15. Yes. How long have I got?
I just pointed up.
Hello?
Let's finish it up quickly.
Yeah, almost done. So just a couple of points on euglycemic decay. This has become a new issue, particularly with the use of SGLT2 inhibitors these days. And this is probably a sort of the reason this is happening is probably our understanding of what diabetic ketoacidosis actually is. It is diabetes and ketoacidosis, not glucose and ketoacidosis, and that's why we have been caught out with patients with diabetic ketoacidosis, which glucose doesn't appear to be too high. Now, generally, I'll just scroll through this quickly because of the time. But this is a particular problem with SGLT2 inhibitors usage in type 2 patients because of the reversal of insulin-glucagon ratio, which cause the gluconeogenesis, and also the dehydration which is caused by SGLT2 inhibitors. So that also leads on to cause of this. So the presentation are not too different, but we may have to remember, because the glucose is not very high, the patient may not have polydipsia, polyuria. So again, patient education is very important. And from the management point of view, because the glucose is not elevated, but these patients will need insulin infusion, we have to start the 10% glucose infusion right at the beginning, along with correction of dehydration by using normal saline. So this is the one slight difference when you're managing this kind of patients as compared to your standard diabetic ketoacidosis patients with type 1. Okay, the key is education, because the prognosis is generally quite good if they're identified and treated properly. And usage of SGLT2 inhibitors has increased massively these days, and because they have got significant benefits on cardiovascular and kidney health, but it has to be chosen wisely. If the patient shows signs of insulinopenia, avoid using SGLT2 inhibitors, which then can precipitate DKA. So if we use it wisely, we shouldn't be getting problems of SGLT2 inhibitor-induced DKA. So thank you very much for your time, and happy to answer any questions.
Thank you, Dr. Basu, for your wonderful presentation. Because the thing is that you have mentioned there was euglycemic decay because we have been using this SGLT2 today, which is quite a lot. So I will just one or two questions from the audience.
Sure.
Any question from the audience?
Probably there is no question from the audience. So I have just one question.
Yeah.
So you are practicing in UK. Now you are finding a lot of patients of the HHS or the decay. So now how common is whether this HHS is more common than the decay in your population?
Well, things have changed quite a lot since the COVID, because during COVID we saw a lot of type 2 patients presenting with HHS. Previously HHS presentation was much less, but with COVID there has been a rise in HHS presentation. We definitely are seeing a lot more DK with SGLT2 inhibitors, but also you can see DK with type 2 patients not on SGLT2 inhibitors, because if you think about the progression of patients with type 2 diabetes, when they become insulinopenic or insulin deficient, they will behave like type 1, isn't it? So they will present with diabetic ketoacidosis. But the trouble is for the HHS is recognition. So when the patient comes in, sometimes they're not always sort of picked up as they have got HHS and they're managed as hyperglycemia. But we certainly have seen more HHS since COVID, and definitely SGLT2 induced diabetic ketoacidosis.
Okay. Any question from the audience? Any comments?
It's a very illustrative presentation by Dr. Basu. So since there are no further questions from the audience, we can conclude the session. And I can just say Shubho Mohala.
Shubho Mohala.
Shubho Sharodiya.
Shubho Sharodiya. Thank you. Thank you.
Thank you.
Thank you so much. Thank you. Have a lovely conference.
Bye.
Bye.
Thank you, speaker. Thank you, chairperson. It's time to felicitate our chairperson. I would like to request Dr. Shoykot Ghosh to please come and felicitate our chairperson. Thank you, sir. Moving towards our next session,